for you, Dr. Fahdah?
Yeah, it's clear, Doctora.
Okay, let's start. So first, of course, now first of all, coronavirus is a single-stranded positive sense RNA virus with a large genome. And actually, it has the largest RNA genes of all the viruses that are known. It has the crown-like projections on its surface, which is very important for its immunogenicity, attachment to the cells, and it is very common that they will be mutating often. So this is their natural history. And they do recombine as well frequently. Usually the coronaviruses are the viruses that cause the common cold. And it is not uncommon that every 2 to 3 years, an epidemic in a certain place will occur, probably with more severe than usual upper respiratory symptoms. However, what is unusual is the pandemic that is happening, like we have seen now with the COVID-19, with the SARS and the MERS. So the big group of the coronaviruses is actually subdivided into 4 categories: the alpha, beta, gamma, and the delta viruses. Mostly for the group 1, which is the alpha viruses, they contain the first described coronavirus, which is 229E, as well as numerous other animal viruses. The beta coronavirus, which is formerly known as group 2, contains the coronavirus OC43 plus other closely related animal viruses. And this is actually, so within the beta group are the viruses that are now causing the upgoing epidemics and the pandemic, including the COVID-19. Group 3, or the gamma viruses, all are only avian, and group 4 are for the avian and swine viruses. So as you see, the human viruses are distributed between the alpha and the beta group. We will take a closer look on the beta group because most of the happening pandemics are actually related to the beta group. So if you can see here with me, this is the group from which the SARS virus, the COVID-19 virus, and the MERS coronavirus as well have originated from. Within the same group, there is noticeable similarity between the SARS one, which was the first described in 2002, and between the currently circulating COVID-19, and hence it is called SARS-2. They do share the same receptor, which is the ACE2 receptor, and they are different, and by that they do differ from the MERS-CoV, which is acting on the receptor CD26. A quick comparison between the 3 mostly described, or the associated coronaviruses and the flu. So if you notice collectively here, from the R naught, which is the basic reproductive number, the coronaviruses have a comparably higher number, especially the COVID-19 and the SARS. So what does it mean that when we say that the R naught for the COVID-19 is 2 to 2.5, it means that each one individual is able to infect 2 or 2.5 other people. And so the 2 more will be infecting, each of them will infect 2 more, so we have 4 more, and so on and so forth. So this is why you notice here that there is very big number of people who are being actually infected just from having one single source because of the R0 number here. For the flu, the number is somewhat lower, so it is 1.3. Some of the big pandemics that happened, like with the Spanish flu, when there was a very high number of mortality and fatality at that point, the R0 was 1.6 to 2, so it's almost becoming similar to the COVID. MERS transmission seems to be ineffective, actually. However, among them, it has the highest case fatality rate. The incubation period for the coronaviruses is longer than that expected for the flu, which is usually between 1 to 2 days. So how is the coronavirus or the COVID-19 specifically transmitted? So basically, the main mode of transmission is by a droplet. Droplet transmission occurs when the particles are more than 5 to 10 micrometer in diameter. So at that point, they are referred to as respiratory droplet. And the droplet transmission occurs when a person is in a close contact, which is within the 1 meter, with someone who has respiratory symptoms. So if he is coughing or sneezing, and this is how it is transmitted. Or it can be, this is what we call it direct, or it can be indirect transmission, which is from the vomit in the immediate environment of the infected person. However, an airborne transmission is different than that, different than the droplet, which is commonly seen in the COVID-19. So the airborne occurs when the particle is very small, less than 5 micrometer in diameter. And it can remain in the air for a period of times that are longer than that described for the droplet, and transmitted as well to others over a distance that is greater than 1 meter. So in context of COVID, the airborne transmission may be possible in specific circumstances. So it's not the rule. So in very specific setting, when there is an aerosol generating procedure, for example, during the intubation, and mechanical ventilation. There is some evidence, however, that as well, other than that, that there is intestinal infection, and the COVID virus as well can be present in feces. However, up to date, there is no documented case that a fecal-oral transmission has occurred, although the virus was isolated in only one culture before. So this is the basic scenario if someone is coughing or sneezing and there is a generation of a droplet. However, we are aware that some of the individuals whom we call silent spreader, so they are actually asymptomatic, and yet they are able to transmit the virus. And it is because the virus is actually present in our body fluids. So it's not necessarily that we're generating a really big droplet, so not necessarily to be huge. We do generate it with usual activities like during speaking. Some people have habitual habit of cleaning their throats, for example, repeatedly. During shaking hands, for example, if he was putting his hands in his finger, scratching his eyes, whatever. So this is how still it can be transmitted even if from the asymptomatic individuals. And once it is transmitted, it will go through an incubation period first before the symptoms develop. So the incubation period, actually, the median incubation period is 5 days. However, most of the patients who will develop symptoms, it will happen in this time. The longer it can come, so the 97% of those who might ever become symptomatic might develop it within 11.5 days, and almost all will have symptoms by the day 14. It's important to note that even during this incubation period and before you have the symptoms, so even if you're destined to have symptoms, the infectiousness will start before the appearance of the symptoms. So usually this it will start with the usual fever, cough. The patient might deteriorate and need hospital admission usually by day 6 to 7. So this is a critical area where you have to be very careful in observing your patient. And those whom later will deteriorate even more and become critical and probably go into ARDS will do so in between 9 to 10 days. However, before you develop any symptoms about the infectiousness, 6 to 12% of all of it will happen here, even before you have any symptoms. And so this is the period that we call it in the pre-symptomatic phase, and it can start from about 2.3 days before you develop any symptom, and it will peak just before, so 0.7 days just before you develop the symptoms. So all this period in the pre-symptomatic, still you will be infectious. A very interesting study that was recently published in a New England Journal of Medicine from the delivery actually words, examining 215 pregnant women who delivered infants recently during the COVID era, but this was in New York, which is an area of high transmission risk. So they discovered that most initially tested negative. However, from those who become positive for COVID, only 1.9% were initially symptomatic. The majority, 13.5%, however, were actually asymptomatic. And when tested, they did have positive result for the COVID-19. So from all the confirmed, if you can see here, this part here, those are all the patients with the confirmed COVID-19. So around the majority, which is 87.9%, actually have no symptoms of COVID at presentation, and of which, again, within those asymptomatics, yet 10% actually developed a fever as some sort of symptoms in terms of fever mostly later on. So one patient as well from those who swabbed initially and the result become negative did develop fever postpartum, and her result turned out to be positive afterward. So it's really becoming tricky with this huge number of and concerning number of the asymptomatic carrier that are still able to be transmitting the infection, and yet they are not showing any evidence of symptoms. So what are the symptoms that we have to be watching for when we are talking about the COVID-19? So it is really a spectrum of disease. So the most common manifestation is fever and cough. Some patients will be presenting with sore throat, so don't miss the sore throat. The other symptoms like headache, fatigue, shortness of breath, runny nose, so upper respiratory-like symptoms, and diarrhea. So as well, loss of smell has been described, and it seems to be characteristic for the disease, and it might actually happen even before the patient develop any other symptoms. Diarrhea might occur as well, and some people have reported abdominal pain to be their first presenting signs with COVID-19. And actually, it is more a multisystemic disease, so it can be affecting everywhere in the body, including commonly what we see is the transaminitis, renal impairment, of course, the gastrointestinal symptoms as well. And don't miss that some patients might be having encephalitis, eye manifestations with conjunctivitis, And of course, they are at increased risk of both venous and arterial thrombosis. So a very important manifestation not to miss, and it is appreciated to be common. So is the venous thromboembolism, which occur in 27% of patients who are admitted with COVID, and arterial thrombotic event occur less frequent, but still it is in 3.7%. So among the thrombotic complications, pulmonary embolism was the most frequent, and it was seen in around 80%. So PE diagnosis actually is very important, yet it might be challenging in patients who are having COVID and they are already under isolation precautions, and it's difficult to perform for them. The CT might be refused to proceed with the CT angio or VQ scan, or actually might be unstable. So be vigilant about it. Just remember that 5 to 10% of the patients with COVID who actually ended up requiring mechanical ventilation might be having an acute PE underlying, and the likely symptoms that will increase your suspicion that probably, yes, my patient with COVID now is having PE, if he has symptoms of DVT, unexplained hypertension, tachycardia, unexplained worsening of the respiratory status, or traditional other risk factors. For example, he's having history previously of thrombosis, cancer, hormonal therapy. So this will be like really a high alert for you. And you can, if you cannot do a confirmatory test for PE, ask for other like bilateral compression ultrasound, probably an echo, to help you like rule out or stratify your patient. So knowing the symptoms, we will go now, if we received a patient from the ER or coming to you, the first thing that we will do is the respiratory triage. So this is basically a very useful checklist that is available through the MOH, and it should be available with all the physicians. And according to this, you will decide if your patient is actually high risk to develop or to have COVID or not. And so it will help us like strategize whom to test and whom to isolate. So it has two basic parts. So the first part is about the exposure risk, and the second regarding the clinical sign and symptom. So for the exposure risk, if there is any history of travel abroad during the last 14 days prior to the symptoms, or if he is resident in the kingdom, however, he is from an area of high transmission rate. And of course, which area of the kingdom is at risk? This is dynamic. This is rapidly changing. So you have to pay close attention to where the COVID is described already in the kingdom. So other epidemiological risk will apply together with suggestive clinical sign and symptoms. So if there is history of fever, if there is history of cough, shortness of breath, nausea, vomiting, diarrhea, or a chronic illness, you will get the scores and calculate the total. So a score that is more than or equal to 4 means that, first of all, you have to tell your patient to perform hand hygiene, wear the mask, and then you will apply the case definition criteria as seen here in the next slide. So what is the COVID definition for a suspected case? Of course, first of all, so if any patient is coming to us with a really unexplained severe acute respiratory illness, this by itself can be a standalone criteria, and you don't have to have any other epidemiological risk. However, for other milder symptoms with acute respiratory illness, including like fever, cough, and shortness of breath, and within the 14 days, we have to apply the epidemiological risk. So if he has those symptoms and within the past 14 days, there is history of travel abroad, or he is living in an area where there is a high transmission for COVID. So for us here in Jeddah, it is a high area for COVID. So this is one. Or he has a close contact with a prior case that is confirmed to have COVID, or he's working in a healthcare facility. So if those criteria apply, this is when we will be proceeding with the testing. What we do is the PCR for the COVID-19, and what we take is the nasopharyngeal swab. So actually, the technique of doing it is very important. You have to know it through the details, and keeping in mind that whenever we are inserting the swab, we have to push it until there is gently, until there is a resistant film. And usually what is recommended that the length of insertion will be equal to the distance from the nostril to the outer opening of the ear. Competency skills testing will be needed for those who are performing a nasopharyngeal swab, depending on your local hospital policy. So after doing the nasopharyngeal swab, we have to be actually very careful with the interpretation. So for a positive test, it is usually confirmatory. So a positive, we don't really have a false positive. So this is highly suggestive or confirmed that your patient actually has COVID-19. However, it is very important to keep in mind that a false negative test do occur, and it is not uncommon actually. The rate of positivity is between 60 to 70%. So still you're expecting like 30 to 40% of your patients to be negative when they are actually having COVID-19. And this is imposing a hazard actually, whether on the patient himself. So if there is like any sort of intervention or treatment procedures that can be done for him, and he will be acting as an unidentified source of infection. So very important to understand that still, even if your patient tested negative, there is a good chance that he might be having COVID-19. Not only, so why is that? Too many explanations, of course. An inherited difference because of the upper respiratory sample sensitivity is lower than if you are able to take a deeper respiratory sample, and we will come to that. I will show you slides in a minute comparing, as well as how is the technique of taking the nasopharyngeal swab. The PCR actually, there are different kits as well. And each of them have different targets. So we have a kit that can identify 1 target, 2 target, and 3 targets. The recommendation is that you will use at least a PCR kit that can identify 2 targets so that you don't mess. So if 1 target, for example, is mutated, still you can identify the other target and will decrease the chances of a false negativity. Not only that, but the PCR is really very sensitive procedure actually when you're performing it. So it can be that just from the way of handling, from the latex, for example, and the gloves of the person who's doing the test might be inhibiting all the whole chain of reaction, and this might explain somehow why we are having the false negative test. So if we compare what is the yield of the PCR according to the sample. So if you can see here, the nasopharyngeal swab rate of positivity is 63%, which is when it is compared to more deeper samples. So sputum might be having a better yield with 72, and bronchoalveolar lavage is almost like 93%, so it has the highest sensitivity. So really it will depend on what sample are you sending, plus the other factors, as we mentioned, the technique, the kits you're using for the PCR, and so on. Of course, there is room for serological testing with the antibody for IgM testing. However, they are actually less likely to be reactive in the first days of infection. Okay, this is not to mention that some of them are difficult to interpret and might be actually giving you, like the IgM, might be giving you a false positive value. So we cannot heavily rely on them up until this point for the diagnosis of COVID. However, later on, probably they might have an advantage that we will know what is the seroprevalence, how many people turn out to be infected before, based on the presence or absence of antibodies for the COVID-19. Some of the home-based antibody testing for the COVID are present, manufactured. They are being sold abroad. However, most of them, there is high alert on them because most are released to the market even with no FDA approval, and the sensitivity is varied. So we cannot rely on them. So you have to be very careful if you're coming across any of them. The other modality that we can use for diagnosis is the high resolution CT scan. So actually, if we are like comparing what is the rate of positivity between the HRCT and the PCR. So in this study, 51 patients were included, and they did for them CT and PCR. Most actually have positive, so 68.62%, both the CT and the PCR were positive. However, and up to 29.41%, although they had an initially negative PCR, the CT was positive for manifestations that are highly suspicious for COVID. So still, even if the PCR still can miss a good number of patients here, and it might be detected with HRCT. What is considered like typical finding for HRCT in the COVID patient? So, so as you can see here, bilateral subpleural ground glass opacity is one of them. Extensive, again, ground glass opacities and consolidations. All those are considered typical manifestations. Some might not be that impressive. However, very clear that we can see that there are areas of the ground glass opacities and consolidation all over. As well as some of the atypical manifestations, as in form of some limited consolidation, linear ground glass opacities, and all. So overall, 72% anyway of your patients are expected to have typical CT manifestations that are mainly peripheral subpleural ground glass opacity, often seen in the lower lobe. And yet up to 28% will have atypical CT manifestations. And I will spend now a short time going through the recommendations for the management of COVID-19. Of course, in the past lecture, we have covered the management options in details, and we went actually through the studies that, that our recommendation now has been based on. So a reminder for everyone that the COVID-19, actually, we can view it as a 3-stage disease. So stage 1, where there is early infection and it's mainly viral response, then the respiratory or the pulmonary phase will be starting, and later on the hyperinflammatory phase will start, and this is when your patient can develop ARDS, require the ventilation, septic shock, and become very critical. So across all the stages, the antiviral, the probably suggested antiviral medications can have a role, like the remdesivir, the hydroxychloroquine, and the convalescent plasma transfusion. Later on, when we are having the inflammatory response. The other managements like the steroids, the interleukin-6 inhibitor, the role of them here might become relevant. So from our current, this is the most recent here, recommendation from the MOH regarding the treatment of the COVID-19. And you can see it here very clearly. So if your patient is suspected, first of all, we'll divide them to suspected and confirmed cases. So if you have suspected, which means that based on the clinical criteria, your patient does have high risk indicators, but your PCR test is still negative. So if he doesn't have symptoms, or he has like very mild to moderate symptoms, actually the recommendation is for symptomatic management and no further treatment is required. However, there is some room if your patient is having shortness of breath. Among the symptoms that he has, there's shortness of breath, or he is a high risk. So who are the high risk patients? So as you can see, probably the elderly patients more than 65, those with underlying end organ involvement, diabetes, other comorbidity, immunocompromised, and pregnant women. So those two categories, even though the PCR is negative, but they are highly suspected still, you might consider treating them, and this has to be individualized on case-to-case basis. Now, what if our patient is confirmed COVID? So if he is confirmed COVID, but he's asymptomatic, you will just do the best supportive treatment together with the infection control procedure that we will come across in a few minutes. However, if your patient does have symptom, mild to moderate symptom, this is when we will start treatment. And the current recommendation from the MOH is that you will start with hydroxychloroquine. And if it is not available, you will be starting with the chloroquine. And as I mentioned before, we have gone thoroughly through the evidence behind each one of them. And we have seen what studies came, the recommendation came actually from. And as a reminder, most of the the treatment recommendations are actually coming from very weak studies. Most were not, don't have a control arm. The designs were not actually like really strong. Even the original journal that has published the hydroxychloroquine study, later on, the same journal mentioned that this was a very weak trial. However, because of course of this current situation and lack of other effective treatment, most of the bodies and issuing organizations and all have included them in their guidelines. So this is for the mild to moderate, as we mentioned, hydroxychloroquine or chloroquine. Now, if the patient have more severe symptoms, so if he's having, he's tachypnic, he's desaturating, and so on. So again, hydroxychloroquine is recommended. And here, when you will consider probably combining it with the leponavir, ritonavir. Now, coming for the critical patients. So the critical patient, we can categorize them into critical patients with or without the cytokine release syndrome. And how do we know that my patient is actually at risk for developing the cytokine release syndrome? So we have well-defined criteria, and any one of them means that your patient is at risk. So if his interleukin level is more than 3 times the upper limit of normal, if the ferritin is more than 300 with doubling within 24 hours, or he presented at baseline with ferritin that is more than 600 and LDH that is more than 250, or if he have an elevated D-dimer. So if you have the cytokine, or your patient is going into the cytokine storm, this is when the tocilizumab, which is an interleukin-6 inhibitor role, comes. However, before you use it, you should be performing the interleukin-6 level and the other inflammatory markers before, and be careful with the infusion reaction. So this will happen on top of, or if your patient is critical, but yet he's not fulfilling any of those criteria, so you will be starting him on the hydroxychloroquine, and here you will always combine it with the lopinavir, ritonavir. Other things to consider are the remdesivir and the favipiravir. So for the remdesivir, however, if there is no contraindication, like your patient, for example, so he's not requiring inotrope because of the concern with the interaction with the norepinephrine, doesn't have renal impairment. So you have to see the other exclusion criteria or the contraindication where you cannot use the remdesivir. Whatever we do, still the proven intervention is the good isolation. So up until this moment, the recommended isolation for all COVID cases is still the droplet isolation. Airborne is only for the aerosol generating procedure, like for tracheal intubation, during the CBR, for example, if he's taking nebulized medication. So this is the only situation where you will go into the airborne isolation. This is the recommendation up to this moment. And fine, so now your patient is already in isolation and you treated him and all, and he is a confirmed COVID-19. So the question is, when can I get my patient off isolation? So it will depend if your patient is symptomatic or not symptomatic. So if there are symptoms, your patient has confirmed COVID-19 and he is symptomatic, so you will wait until he is becoming asymptomatic for 48 hours. And then what you will do, you will now start performing the COVID-19 PCR. So if it is negative, you have to repeat it in 24 hours and document that it is negativity. After that, he can be discontinued from the hospital isolation. However, when discharging home, the period of 14 days still has to be actually taken. Very important to remember it. However, if your patient is still testing positive, so you will be repeating the PCR every 72 hours until you have it negative. And again, once negative, you will be repeating every 24 hours. Now, if your patient actually from the beginning, he is not symptomatic, so the PCR should be done in 72 hours until you have the first negative. And it's always a rule that when you have the first negative, you will be repeating the PCR in 24 hours to confirm. So we have two consecutive negative. What if he's only suspected? We never had a positive PCR for him. So if he is clinically stable, we will advise for the home isolation. And if not, he's admitted in the hospital. So we should maintain the droplet isolation for 14 days. Of course, at any point, if the test is converted to be positive, so the patients will be treated in accordance to the previous graph that I showed you for patients with a confirmed positive PCR. Prevention is really the most important thing for COVID. And if we have a vaccine, like now this is the $1 million actually question. So too many trials are happening with too many actually different targets have been proposed. However, those that passed and are actually undergoing trial for the human are very few, but one study has been recently started and still it is an ongoing trial, and the result is expected to be released in June next year, 2021. It is an open labeled non-randomized trial that is still ongoing. So we will wait for the result for the efficacy and for the safety of the currently proposed vaccine. Some studies as well are being done on the post-exposure prophylaxis. So if you are exposed to someone, ongoing trials are there. Two are happening right now, studying the hydroxychloroquine as a post-exposure prophylaxis. One is expected to be released in May and one in June this year. And from whatever we see, actually, really what is standing out other than what we do as an effort to find the new medication, what is proper and not. And up until now, the most important thing is applying very careful infection control procedures and going with the social distancing recommendations and all. So the aim actually is for us to flatten the epidemic curve, which basically means that if this is the capacity of our healthcare system, what we are trying to do, we don't want the cases to peak very rapidly and exceed our ability to accommodate the patients. So the aim is to get a more flatter curve where we have a gradual rise. So maybe at the end, we will all have the same number, total number of those getting infected. However, we can slow the rapidity of having the cases appearing, hopefully not to exceed what is the capacity of our health system. And at the same time, the capacity, we are trying to increase it, for example, by having more available hospitals there, more beds to be available, ventilations probably to be ready when they are needed. So this is what really where the money is. It is more about the prevention and trying really to slow the progress of the disease as much as possible. Of course, the final reminders here that when you're interpreting data on the COVID-19, be very careful from taking a conclusive results from the weekly design studies. So we have seen too many of them doesn't really have good design. They don't have solid scientific basis. Some of them are even not in a peer-reviewed journal. Some information are being leaked even before being published, and we don't know the full picture of it. So be very careful when interpreting the data on COVID-19. What is the view for post-COVID? So too many things have changed actually now for us in the area of COVID, and probably even in the era after the COVID-19. Things might not be the same as it has been. Now we are more aware actually about the transmission. Some of our habits have been changing, like for shaking hands, how close can we be, how safe actually are we being when we are close to someone else. And there are some speculations. One study actually has tried to model the SARS-2 or the COVID-19 transmission if we remained in the same situation that we are now, which means that if we don't have any vaccines and we don't have a curative treatment. So some speculations say that probably on and off social distancing might be needed for the coming future. Hopefully a vaccine will be there. And then there are more questions actually about the vaccine. So if it is able to mount a sufficient immunity to protect us from the COVID-19 or not, and for how long this immunity will be sustained. So I guess this is a thing that we will see in the future. And I hope that you get benefit from this lecture. And thank you everyone for listening and attending. Okay, so we will move to Dr. Fahdah.
Yes.
Yeah,
thank you, Dr. Thank you, Dr. Nada.
You're welcome. So we will be moving now to the second lecture with Dr. Fahdah Almutairi. Dr. Fahdah is an infectious disease clinical pharmacist and antimicrobial stewardship program pharmacist, one of our distinguished colleagues here in King Fahd Hospital in Jeddah.
أيوة أهلا دكتورة.
Yes, تفضلي.
Okay. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. كل عام وأنتم بخير. I will start my lecture. Clear دكتورة presentation. يمكن بس.
لا, I cannot see it.
Okay, this is slide. Okay. الحين واضح دكتورة؟
Yes, now it's clear.
Okay. خلاص من غير هذا. It's okay. Okay, the lecture today will just continue for what have been started with Dr. Nada about, we're still talking about COVID. I will focus about the pharmacotherapeutic treatment, the related interaction and side effect, and what we need to monitor. Before to start talking about the medication, I'll just start with a small introduction about the virus, just to help us know the drug target and the site of action for each medication. As you know here, that coronavirus is a single-stranded RNA genome covered by an envelope structure. There are most important protein in the virus. The most important one is the spike protein and the membrane protein, also the envelope protein, as well as the nucleocapsid protein. The COVID attached to the target cell with the help of this spike protein, the host cell protein interaction, then the virus genome with its nucleocapsid released into the cytoplasm of the host cell. As explained in the previous lecture, that the coronavirus is divided into divided roughly into three main phases. That the first one is the stage one is an asymptomatic incubation period, usually with or without detectable virus, and usually the treatment here is as a supportive, or sometimes if the patient is asymptomatic, it will not need any treatment. Second phase, this is, or second stage is also second phase is non-severe symptomatic period with the presence of the virus in the blood. And some patient in this stage or in this phase, it might need to use some antiviral medication, such as one of the antimalarial or other antiviral. The most severe phase is the cytokine storm phase. In this phase, usually in which that an excessive immune response will happen with as the disease also progresses rapidly, and also the mortality will increase in this stage, and also other medication can be used in combination. Here, this is the a list of the medications that have been used in the treatment of coronavirus infection or coronavirus patients. These are including some of antiviral, such as lopinavir-ritonavir combination, arbidol, ribavirin, and Tamiflu. The other class is immunomodulatory drugs, such as tocilizumab, or the other antibacterial for the treating of COVID-associated pneumonia, associated bacterial pneumonia, such as tazocine, or azithromycin for the atypical. Anti-malaria also has a good part for the treating the coronavirus infection, such as hydroxychloroquine and chloroquine. Corticosteroid also has a controversial role in the management of coronavirus. This schematic represents virus-induced host immune system response and the viral processing within the target cells. And as you see here, there are different...
can you please just enlarge the slideshow so we can see better? Just make it...
okay.
Yeah. Yes, thank you.
This one, okay. As you see here, there are different sites of the medication have been used for treating coronavirus. And in this schematic, it shows also some preceptor. Here, the angiotensin converting enzyme 2 receptor, also the also here the other receptor is the transmembrane serine protease and soluble interleukin 6 receptor. We will start with the first medication here is the chloroquine, hydroxychloroquine from the antimalarial class. Both hydroxychloroquine and chloroquine are commonly antimalarial agent, and they are considered a part of current treatment guideline for rheumatoid arthritis and some other autoimmune disease. Both these two medications have antiviral and anti-inflammatory action, and it also involve other mechanism also involve angiotensin converting enzyme 2 cellular receptor inhibition. Here we are talking about the pharmacokinetic properties of these two medications. As you see here that hydroxychloroquine and the chloroquine is administered as administered orally. Hydroxychloroquine is administered as a sulfate, whereas a chloroquine administered as phosphate salt. And both drugs here, after absorption, they possess a long half-life, which reach up to 2 months. So the volume, both of them also owing a large volume of distribution. The hydroxychloroquine is lower volume of distribution compared to chloroquine, and this will associated with the side effect of the medication. So we will just explain it later. So the pharmacokinetic characteristics of both medication is complex owing to this large volume of distribution and also the longer half-life. This is the dosing. We will start usually in the first day as a higher dose divided in 2 doses, then as a maintenance dose, also divided twice daily for up to 7 to 10 days. The safety profile for these two medications, they are both the most common adverse effect of the antimalarial drugs are gastrointestinal drugs, including nausea, vomiting, and abdominal discomfort. It also reported that these medication will associated with cardiotoxicity. It's demonstrated as the conduction abnormality, rhythm disorders, prolongation of QT interval. And another most severe complication, which is attributed to the antimalarial treatment, is the development of retinopathy. And this is mainly happen if they have been used these medication for long term. And because hydroxychloroquine or these two medication will bind strongly to the melanin and can deposit in the melanin containing tissues, tissue in the skin and also in the eyes. So this will explain the mechanism of action is that the retinopathy, or also the efficacy of these two medication when it's being used for the some skin manifestations. the clinical observation that suggests the hydroxychloroquine is associated with the lower risk of retinopathy than chloroquine, which might be explained by the lower volume of distribution. Lower of distribution compared to chloroquine is as seen here in this figure, that the hydroxychloroquine has a lower volume of distribution. So the other side effect is that both medication also have a metabolic disorder in terms of causing hypoglycemia. So it should be used in caution in the patient with diabetes, or those patients have impaired liver function. There are also some drug interaction with these two medications. There are two types of the interaction, or two mechanisms of action of the interactions. That the first one is the pharmacodynamic drug interaction. Occur when there is synergistic or antagonistic effect of two or more drugs at a specific receptor. And both medication, hydroxy and chloroquine, have an interaction that are attributable to this type when as both of these medication have cardiac and arrhythmogenic effect to cause, as mentioned, QT prolongation and also the conduction abnormality. And the most curious thing here is that one of the regimen being suggested for the treating COVID patient is the combination of hydroxychloroquine with azithromycin. And this combination, which raises the potential that concern regarding additive or synergistic QT prolongation. Both medication also, act as a substrate for cytochrome P450 enzyme, and this enzyme responsible for metabolism of different medication, and also it can interfere with other drugs. Also, there are some medication can interfere with the bioavailability of hydroxychloroquine and chloroquine. Some of these medication is a proton pump inhibitor. The other medication used or have been tried for the treatment of coronavirus is the lopinavir-ritonavir combination. This medication, it is a well-known combination, a well-known antiretroviral medication used for HIV infection, and it has been suggested as a possible also treatment of COVID-19. This will inhibit the viral replication through blocking the protease enzyme. Lopinavir is an antiretroviral protease inhibitor used, as we mentioned, as in combination, and ritonavir is combined here as an potent inhibitor of enzyme responsible for lopinavir metabolism and the co-administration to post-lopinavir exposure and improve the antiviral activity. Here is the pharmacokinetic of this combination. It has different based on the age that the children have a higher concentration compared to the adult. It is also excreted through feces, and in some study it did not need any adjustment in renal impairment. The dosing of these combination in coronavirus infection is 2 tablets of the 200 milligram twice daily. The safety profile or the side effect of this medication, it's also shared the same of cardiotoxicity. It's causing QT prolongation. It is also affecting the liver enzyme by causing also hepatitis and also liver impairment. It should be also used with caution in patients who have previous pancreatitis. And with those who have metabolic abnormalities caused lopinavir-ritonavir combination can increase the triglyceride and cholesterol. Also, it causing hyperglycemia. This medication have also a significant drug interaction with some medication. These here, the drug interaction with it increased the alpha-leucine concentration. It has also an interaction with certain antiarrhythmic medications such as amiodarone by causing also and predispose the patient for cardiac arrhythmia. It has an interaction with the anti-hyperlipidemic agent. Also, it might increase the risk for myopathy and rhabdomyolysis. It cause also increase the sedation or might increase the risk of respiratory depression when combined with certain sedatives such as midazolam. And others also with voriconazole, the level and the concentration of ritonavir, lopinavir combination will increase. The other class of medication have been used here is the RNA-dependent RNA polymerase inhibitor. There are 3 examples of the medication here, ribavirin and remdesivir and favipiravir. We will start with the remdesivir as a prodrug nucleoside inhibitor, which is one of the strongest candidate from the COVID-19 treatment. And it showed also one of the promising potential therapy due to its broad spectrum against some virus. How remdesivir work? Remdesivir here, as you can see, that the SARS-CoV will enter target cells by binding the S protein, the green part here, to the ACE or angiotensin converting enzyme 2 receptor on the cell surface. Then the remdesivir act as a RNA dependent RNA polymerase inhibitor and can be provide a block for the RNA replication. So once the remdesivir is added to the growing chain, it will not stop immediately, but it will continue to extend for more nucleotide, and then to the final step is forming the remdesivir triphosphate. The main, in terms of safety of remdesivir, there is atypical antiviral side effect, which is as a gastrointestinal intolerance, as nausea and vomiting. And in some Ebola trials, the researchers noted that there are some side effects of remdesivir besides the gastrointestinal tract. These are the increased liver enzyme levels, and that might indicate predispose the patient to the liver damage. And the researcher documented also similar increases in the liver enzyme in 3 United States COVID-19 patients. So the close monitoring of the liver function should be done for those who are starting in remdesivir. The second agent in this class is favipiravir. Favipiravir is a prodrug of a purine nucleotide. The active agent here is also, as you see here, it is inhibit the RNA polymerase, and once the favipiravir incorporated into the cells, it's converted to favipiravir ribofuranzoyl phosphate by the host cell. And this to form the triphosphate form inhibit the virus, the influenza virus. And this agent favipiravir has exhibited dose and time dependent pharmacokinetic, and it's usually eliminated by metabolism by the enzyme aldehyde oxidase. This agent has a mild adverse effect profile, and overall it is well tolerated. The main side effect of favipiravir is diarrhea, asymptomatic increase in the blood uric acid. It has a risk for those who has gout, and also increases, it might cause neutropenia. The main drug-in-drug interaction for favipiravir, there is one study showing it has interact with the oral anti-diabetic by increasing the exposure of up to 50%. The other one is ribavirin, one of the antiviral synthetic guanosine nucleoside analog. It has also antiviral activity against a broad range of RNA viruses. It is administered orally in 2 divided doses. It is also renally excreted, and the main side effect of ribavirin is hemolytic anemia. It is this hemolytic anemia is mainly dose dependent, and it is one of the most common side effects. And approximately 2/3 of the patients who are treated with ribavirin usually experience anemia, but less than 1% of patients develop severe anemia, and the hemoglobin level usually return to the baseline within 4 to 12 weeks after stopping the medication. And this anemia is due to the accumulation of ribavirin in erythrocyte. Other common side effect associated with ribavirin is like pruritus and rash. Also, some serious side effects will include acute gout. Regarding the interaction that ribavirin has and interact with abacavir, in which increasing the risk of lactic acidosis and also increase hepatic decompensation. Now, the third class here is the immune modulatory drugs, which is the interleukin-6 receptor inhibitor, the tocilizumab. Tocilizumab is approved in 2008 as the treatment of rheumatoid arthritis, and it is a recombinant monoclonal antibody. It is given as injection, subcutaneous medication. This tocilizumab has most common adverse event, and also in randomized trial, the rate of these, it has the infection as a common side effect, and it increases usually after 3 weeks of 3 months of a treatment. The other side effect is the infusion reactions occurring within 24 hours of the infusion, and were reported in 7% of those who are receiving tocilizumab in a dose of 8 milligrams per kg. The treatment with tocilizumab usually often associated with other side effects such as development of neutropenia, but usually generally mild. And because patient with rheumatoid arthritis is using this medication for a long period of time, while here the recommendation for using tocilizumab in COVID is as a single dose. So here the efficacy of tocilizumab, consider usually starting tocilizumab as mentioned in the previous lecture in severe critical stage of a disease, and there are criteria for starting tocilizumab at a high risk of developing cytokine storm, such as serum interleukin-6 are more than the normal limit, high ferritin, and elevated D-dimer. Tocilizumab drug interaction, there are drug interaction with the live vaccines in order to decrease the efficacy of these vaccine, also with the immunosuppressant, so it might increase the risk of infection, and also with the simvastatin by increasing the concentration of the simvastatin and predispose the patient to rhabdomyolysis risk. The other medication here is the Arbidol. Arbidol has shown to display also antiviral in vitro and in vivo activity against a lot of number of enveloped or non-enveloped RNA or DNA viruses. Arbidol has been studied in the phase 4 trial in 86 patients with mild to moderate COVID-19 and has indicated that it did not improve the clinical outcomes when compared to the lopinavir-ritonavir drug. Now we will talk about the adjunctive therapy. Those are the medication used during COVID-19 treatments, such as corticosteroid, antipyretic, and also the angiotensin-converting enzyme inhibitor. Regarding corticosteroids, the current stand for corticosteroid use in COVID-19 is still controversial due to the concern that it may delay the viral clearance from the body. However, in the practice, the use of steroid, they are using steroid 1 to 2 milligram per kg body weight for 3 to 5 days and is used frequently. And also this will use in order to improve lung inflammation to prevent the development of severe acute respiratory distress syndrome. But by the WHO, it's not recommended. The antipyretics is considered as a part from the supportive treatment for all patients who have COVID. And as we know that the number of cases of COVID-19 continues to rise, so this using antipyretics stay as the main therapy for those patients with mild to moderate, from mild to moderate symptoms of COVID-19. So there are recent reports of potential harm with ibuprofen, and there are some clinicians saying that ibuprofen should not be used for managing symptoms because they have seen that it might harm patient. And this news or this statement, it started when one doctor reported 4 cases of children who took ibuprofen and experienced worsening symptoms of COVID-19 infection. But still, these 4 cases is not published yet. This opinion will go to the WHO, and they have taken that. And they suggesting that, but WHO, they are suggesting that those patients use acetaminophen as a first choice of antipyretic until more evidence is collected. And they also, but they still were reviewing against using ibuprofen as a part from antipyretic treatment for those patients with COVID. And they argued also that the coronavirus, there is another theory behind that the coronavirus bind to the angiotensin converting enzyme 2, and the administration of this ibuprofen can increase the bioavailability of angiotensin converting enzyme 2. Therefore, this will be a potential to enhance the infectious processes of coronavirus. And this current evidence or this argument is still not yet strong enough to infer the link of a harmful effect of ibuprofen in the patient with COVID-19. So it's need more evidence, and the evidence from that alone should not be used to make a strong statement against using ibuprofen. The AC inhibitors and angiotensin receptor blockers, COVID-19 also, and angiotensin and the angiotensin receptor blockers. This is it help or harm during patient with who have hypertension and on the same time have COVID. This table just showing the underlying health condition in hospitalized COVID ICU patient. It's showing that most of them have higher percentage with hypertension. And there are Also here, the hypertension mortality showing a high percentage among COVID-19 patients. The report showed that that the unclear whether uncontrolled blood pressure is a risk factor for acquiring COVID-19 or whether controlled blood pressure among patients with hypertension is not a less or a risk factor. So the fact that hypertension and other forms of cardiovascular disease found frequently in those patients, and often treated, some of them, they have been treated with the AC inhibitor or angiotensin receptor blocker. And that the COVID is causing, the SARS-CoV causing COVID-19 bind to that receptor angiotensin converting enzyme 2 in the lung to enter cells. And this will kind of raise a question regarding the possibility that these agents could either be beneficial or harmful in a patient who are treated with AC inhibitor or ARBs. With the respect that also susceptibility to acquire COVID-19 in a relation to its whether improving outcome or worsening the outcome. Until now, there is there is no evidence that the hypertension is related to the outcomes of this of that AC inhibitor or not. But there is no recommendation against use AC inhibitor or ARB for the patient who having hypertension. Here, the last of the presentation today, which is also one of the important question regarding patients who are taking oral medication, that the administration of tablet or capsule in cases of swallowing difficulties. There are some are not recommended to crush tablets, such as lopinavir, ritonavir. Ribavirin capsule also cannot be open or break with for hydroxychloroquine. It is controversy. There are some studies recommend to give in the patient who are on nasogastric tube and can't swallow. And for favipiravir, it can be also crushed and can be mixed with a liquid. With lopinavir, ritonavir, the study showed that after crushing tablet, the concentration might be decreased to the up to ranging from 5% to 70%. But this study was only in pediatric. So regarding adults, there is no studies. And in the other hand, there is also an oral solution or oral suspension is available. Also, there is a compounding, so it can be prepared for those who have NGT tube. Now, as the final of this lecture, the take-home message that COVID has been declared a pandemic by WHO. As you know, the increased cases globally have highlighted the need for updated management guideline. COVID-19 patient with combined underlying diseases, diabetes, cardiovascular disease also, and those might have more progress disease and more inflammation. Currently, the supportive management usually still the first line of a treatment. New medical therapy are currently in phase 1 and 2 trial. The medication regimen for those patients are more complicated in general, and there are many interaction between antiviral drugs and other symptomatic drugs, and the medication efficacy and safety may be affected. And as you see from the lecture today, that most of the medication are affecting liver by increasing liver enzymes. So it's need to close monitor for liver function and as well as the CBC. Thank you for your listening. Yes.
Thank you, Dr. Fahdah, for your really informative lecture. So there are too many things that we have to keep in mind actually when treating patients with COVID, including that our medication that we're using might be actually harming them. So thank you, Dr. Fahdah. Now we will be answering the questions. So one question is from the lecture of Dr. Nada, around 80% have VTE. So is anticoagulation part of the treatment regimen? And what is the role of blood transfusion versus plasma exchange? So that's a really interesting question, actually. Just to, for note, it's not 80% associated with VTE. So actually it is 27% of the cases are associated with VTE or venous thromboembolism, of which 80% are pulmonary embolism. Yes, anticoagulation is a very important part of the management of the patients who are admitted with COVID. And actually it is part of the protocol by the MOH that all patients who are hospitalized with COVID should be on anticoagulation, provided that there is no contraindication like severe, they're actively bleeding, severe thrombocytopenia, and so on. And the recommendation is for the use of the low molecular weight heparin. Regarding the question of the blood transfusion or plasma exchange, so there are some observations for the use of the plasmapheresis, probably the blood exchange, more of like, and the rationale behind it when it has been tried. Now, this is not like something unique for the COVID. This is with usually with severe infection. So some trials will come that we can some sort of remove the inflammatory mediators that are present in the system through similar mechanisms. So yeah, there are some trials on the plasmapheresis actually. Hopefully it is helping to remove the cytokines and all, but keep in mind that this is very limited, have been tried out of desperation actually in patients who are very sick, ARDS patients with a cytokine storm already, and the plasmapheresis is not without its own risk. So no conclusive evidence so far, but it has been tried, so we'll wait and see. The other question is, again, thanks Dr. Nada for the, so any feedback regarding the use of steroid and other immunosuppressive therapy earlier in the viremic phase so as to delay the progression of severe cytokine storming phase? Yes, so this is another very important question actually, and it has been addressed. So the IDSA, the Infectious Disease Society of America, have released a guideline somehow for the COVID-19 management so far. And they mentioned that for the recommendation for the steroid, so to give it for all hospitalized patients or the patients who are not critically ill, they recommended against the use. So no, we don't use it for patients who are not in ARDS and not critically ill patients. So there is a recommendation against its routine use, no rule for like prophylaxis or to prevent the cytokine storm. However, patients with already established ARDS might benefit. So according to the IDSA guideline, with the current evidence that we have actually, that you might try it in really sick patient where we are desperate and we don't have too many options. Mind you that up to this moment, there is no specific study that is really addressing the question, should we use the steroid or not? It came from observations from bigger groups in China that they were using the steroid. However, the results are non-conclusive. And some actually showed that there is delayed clearance for the virus. So we have to be very careful with the steroids, no rule for prophylaxis when using it. Might consider it in ARDS more because we're desperate and we don't have too many other options to do. So, another question, so we can say the treatment was found and still looking for, or we just treat the symptoms. So, thank you. So actually the really established measure up until this moment is supportive care. And of course, very important that you will be controlling the spread of infection. So we cannot emphasize enough on the importance of early detection, maintaining high index of suspicion, meticulous evaluation and testing for all your patients, early isolation when needed, maintaining afterward like the social distancing, all the infection control measures. So this is where the real deal is. Yes, the medications, we're still looking for it. Whatever is we're giving actually is advice to be given in the context of a clinical trial, and we will wait and see what will happen. So hopefully, whether it is a new medication that we will be discovering will help. Some seem to be promising. Too many have really conflicting results. Vaccines might be a good option if we do have the effective vaccine. So I guess what we can say is that we will wait and see. Any comment from your side, Dr. Fahdah?
Nothing. It just as what you mentioned, Doctora, we still all the medication now we used is don't have the strong evidence. And it is beside the supportive treatment, this medication is still tried, and some of these showing a better or improving the clinical outcomes than other. But still, they are trying also to have tested other medications. And some of these also, like remdesivir, it's showing a good or better clinical outcome, but we don't have here, and it's not registered yet in our kingdom.
Yeah, so not registered, and if we're gonna use it, probably
still need
pathway,
certain criteria.
So, yeah, exactly. Thank you very much, Dr. Fahdah, and thank you everyone for attending, and I hope everyone will have a nice day. Thank you.
Thank you. كل عام وانتم بخير.
وانتم بخير إن شاء الله.